Good afternoon. Can everybody hear me okay? Okay. I'd like to welcome you all to this session of the Plain Talk series that we are doing in partnership with the folks from COAAA. This month's talk is on how to talk about hospice and palliative care. Next month, we will be having another one on how to talk to your doctor about your diagnosis and treatment options. So I'd like to go ahead and introduce Brad Jackson, a friend of mine, who's going to talk to you today about hospice and palliative care. Thank you.
Hi there. This is a little strange for me. I don't think I've ever done one of these where I was being videotaped. So if you spot me doing anything embarrassing, like go to anything like that, just do like this or something, and I'll remember not to, for the benefit of everyone else who comes after you to see this. So, like Julie said, my name is Brad Jackson. I'm the manager of spiritual care and bereavement with Summit Hospice here in Columbus. I've been working in hospice and/or palliative care and/or chaplaincy since 2007, I think, and having conversations like this one in this room, and then having conversations like the ones we're going to talk about, are part of the things that really kind of draws me to this work, that I'm very passionate about, and that I am really passionate about seeing done well. So that's what we're going to talk about a little bit today. I have my clicker here. I think I'm all set. So, before I get started, so I am going to plow through some slides here. Julie has emailed version, so if you would like copies of this to take with you at the end of the day, I didn't feel like killing the trees to print everything because I didn't know how many were going to be here, etc. I'm sure Julie would be happy to send you an email. And then also there are a couple of handouts. One is just our company's brochure, and one is something that I'll refer to as we get going. So let's get started. So I'm going to start with a quick story. I got a call a few weeks ago to go to a local assisted living facility. Their director of nursing called and said, hey, I have this resident who I believe, it's time to kind of start talking hospice with her. And so she said, would you mind coming to do that? And I said, yeah, of course. And I said, does this patient know I'm coming? Does she know that this is what's happening, right? Because one of my kind of guiding principles in this is you don't really want to cold call with this conversation, right? She's like, oh, yeah. She's totally fine with it. She's ready for you. Her family's ready for it, everything like that. So I'm great. So we set up the appointment. I show up, introduce myself as being from Summit Hospice, and the patient's eyes go like this. And I'm in my head, I'm just like glaring a hole through this this lady at this facility. What she had said to her was, there is a gentleman from a home health agency who's going to come talk to you about getting you a little bit of extra care. And on two levels, I was very upset about this. One, because it's super embarrassing for me, right? I come in and I sit down and I start talking about who I am and what I do, and the patient immediately gets a little defensive, a little agitated. She was afraid, right? And then on the other hand, it doesn't do her any good to be surprised with this, because now she's in kind of a heightened emotional state. She's not going to be able to process the information that I'm giving her appropriately. Now, we kind of fixed it, but it was a rocky road, right? So what I'm trying to do today is communicate how to avoid that particular thing from happening to anyone. So the problem, many clinicians, and I would extend this to the larger community, many people have a hard time discussing hospice and palliative care amongst themselves, with the families that are under their care, or just generally kind of out in the world. We kind of don't necessarily embrace this conversation in ways that make the transition helpful. So today's objective, by the end of our discussion, we should all feel more comfortable with this topic, both with what hospice and palliative care are and are not, how to talk to the folks in our lives or the patients and families under our care about hospice and palliative care, and hopefully we'll just have a little more knowledge and a little bit higher comfort level with these discussions. So, as we get kind of more into the meat of this, I'll say one more thing. Don't hesitate to stop me and ask a question. I know that, even though there was a mailer sent out and everything and invitations, I know you didn't come because you so desperately wanted to hear me talk for an hour. So please stop me and ask a question if you have one. So let's establish a couple of things. Hospice and palliative care are not interchangeable terms. That is, I know we're going to get this one out of the way early, but if there is one thing that you leave here, one piece of information you leave here with today, is that these two things are not interchangeable. I can't tell you how many times I have made a phone call to a prospective admission, or that I have walked into a room with a prospective admission, and this resident or patient's nurse or doctor or family or someone has told them that they were going to be consulting palliative care when in fact they were consulting hospice. Okay? And that sets people up for very similar reactions to what I described with this first lady. So, the analogy I like to use for this, if you remember your high school geometry, is that a square is a rectangle, but a rectangle is not a square. Correct? Everybody remember that? Anybody better at geometry than I was? So hospice is a type of palliative care, but palliative care is not hospice. Okay? So both palliative care and hospice provide comfort, but palliative care can begin at the time of diagnosis, and at the same time, and it can run concurrently with treatment. Hospice care begins after aggressive and curative measures have stopped, and we're recognizing that a person's illness is not going to improve, that a person's illness is terminal, and that they very likely have a prognosis of 6 months or less. So that's as clear as I can be about this, right? In that same encounter that I began with, the nurse, from this facility that was there said to the patient during our conversation, hospice doesn't mean you're terminally ill. It just means we're getting you a little extra help. And in my head, I'm going, no, that's not what it means, right? So I think especially with these conversations, it's so important to be clear and to be correct, right? So, palliative care is designed to treat and manage symptoms that arise as a result of a serious diagnosis. Treatments for pain or other symptoms can run concurrently with aggressive curative treatment. I mentioned that a minute ago. And again, once a person elects to stop curative care, then hospice is likely warranted. Okay? I think it's essential that clinicians can describe this diagnosis or describe this difference. And again, as you can imagine, given some of the scenarios I've described, you can imagine how not being able to be clear about this can really muddy the waters for folks who maybe don't have as sophisticated an understanding of what we're talking about, right? So my specialty particularly is hospice, so that's what we're going to talk about mostly today. So when we talk about hospice, what are we talking about? Hospice is a type of palliative care. It's designed to treat and manage the symptoms related to a life-limiting illness or terminal diagnosis in patients whose physicians reasonably believe to have a 6-month or less prognosis. Now, this is a very important thing that I'm going to say, and you can see it right here. That doesn't mean that there's a hard and fast cutoff at 6 months, right? That's generally the first question I get when I say that first part to somebody. Well, wait a minute, what happens if I live longer than 6 months? Or what happens if my dad lives longer than 6 months? Well, under the Medicare hospice benefit, as long as someone admitted to hospice continues to show signs of decline, Medicare will continue to cover those provided services. So while it is not typical, it is also not unusual for people to, be on hospice for 9 months, a year, sometimes even longer, right? Those tend to be outliers, but it's not unheard of and it's not unusual. A little bit about the Medicare hospice benefit. provided that physicians, I say 2 physicians here, that is the standard. There are some caveats to that are less important for this setting, but provided two physicians certify that a patient is terminally ill, the Medicare hospice benefit provides for physician and nurse practitioner services, nursing care, medical equipment and supplies, medications for symptom management and pain relief, multiple levels of hospice care. So there are 4 levels of hospice care that we can talk a little bit about. Inpatient respite, crisis care, home health aid services, counseling. That generally means the services of a social worker or a chaplain or spiritual counselor. Hospice providers use those terms kind of interchangeably. Spiritual care, volunteer participation, bereavement services. Under the counseling umbrella, dietary counseling is also can also be provided by the hospice benefit, and I am sure there are others. Yes.
I'm curious on the home health aid.
Mm-hmm.
We frequently will come in and kind of supplement with hospice services.
Okay.
How are the hours determined that will be covered by hospice versus that which the families get on the hook for?
Yeah, that's a really good question. The question was, how are hospice STNA hours kind of determined versus what a home health service would provide? Yeah. So basically, visit frequencies are based on patient need, right? Now, hospice aides will generally provide personal care, hygiene, and grooming, right? So however long that takes. Hospice doesn't bill and doesn't set out those care plans in terms of hours. So what I always tell folks is a pretty standard hospice care plan is 2 or 3 visits a week from an aide if you're at home. Sometimes more than that if necessary, sometimes less than that if the patient either doesn't want them or doesn't need them. We have some patients who are still physically able to do some of that care, so they're like, no thank you, I don't, right? So that's the patient's needs drive visit frequencies. And what I tend to tell families is a typical aid visit, depending on the patient's needs, anywhere from 45 minutes to an hour and a half is a pretty good range. Sometimes more, right? Because if you have a hospice patient who has advanced dementia and they're in a dementia unit and maybe they don't necessarily respond well to care, right? Those can take a little longer sometimes, right? So that's a pretty fair estimate of how that's done. Yep. Anybody else?
The home health aides
Mhm.
that hospice provides, they're typically only providing personal care, correct? So
Mm-hmm.
not along the lines of companionship, meal preparation.
Correct. Yeah.
Homemaking, things like that.
Right. Prior to, I would say probably 6 to 8 years ago, homemaking and meal prep was actually a big part of what hospice aides did. Now, as the industry itself grew and people's time was shorter, then I think, unfortunately, in my opinion, those are some of the services that are kind of left out in a lot of cases. Now, sometimes you get the aide that has a lower caseload than maybe others that has time to spend a little more time. And I always encourage our aides to don't just go in and get out. Spend some time, spend some TLC. I visited one of our patients yesterday, and our aide was just sitting on the couch with her, holding her hand and watching TV. And little gestures like that, I think, are important. Right? So, but in terms of like homemaking, that's not typically what you'll see.
Can the volunteers do any of those tasks?
Yes, ma'am. Can the volunteers do any meal prep and homemaking tasks? Yes, I think is a fair answer to that. All volunteer interventions are just like any service, any clinician interventions. They have to be care planned, right? So I'm thinking along the lines of outside of what is good for the patient's day-to-day, liability concerns as well. So like what happens if our hospice volunteer goes in and cooks something for somebody and it makes them sick. So I would lean away from that, but I think it's something that I don't have any issue with a hospice volunteer going in and like heating somebody's Meals on Wheels up, right? Yes, ma'am.
In terms of volunteers, how much do families, do they know that they can ask? I wonder how much the average person on hospice has volunteer involvement, because I find that it varies a lot from place to place.
It does vary a lot. And the question is, and I'm repeating the questions for the recording. I know you all can hear. The question is, how much do families know about the volunteer benefit, essentially? There is wide variance in how much people know about this. From my perspective, a lot of times the way the referral process goes down, whether that's something that's very urgent, and like a more urgent hospice referral, maybe families don't have as much time to digest information. But Medicare requires hospice providers to offer 5% of their in-person care by volunteers. Like, we're required to meet that standard. Now, that's across our entire caseload. So that doesn't mean that every single hospice patient is seen 5% of the time by a volunteer. They may be, some may be seen 20%, some may be seen 0, if that makes sense. Okay? I'm terrible at math. So I just know that if you combine those, at some point you'll get 5. But I would say a lot of times hospice volunteers are more for companionship. We have ours do life review type conversations with us. We have one of our volunteers is actually a master's in social work intern from OSU, so he's got some clinical skill as well that he can go in and have good kind of counseling type discussions with folks and recognize possible interventions that we can do. So there's wide variance. Some hospice volunteers are the families of former patients. Sometimes they may not be able, if you can imagine someone's elderly widow who may not be able to get out and volunteer one-on-one with visits, maybe they can knit blankets, right, that we can then deliver to our hospice patients. It's a really pretty wonderful service that people provide. Okay. Bereavement services, I'm going to point this out really quickly because it's kind of the thing that I do. Medicare also requires hospice agencies to follow families after time of death for a period of 13 months. Doesn't require any particular type of following. It's very, up to us how we do that. What's generally typical, periodic mailings, phone calls, just kind of check-ins. Most hospices will provide some programming as well in terms of, support groups that are open to our patients and open to the public. We do, and I think just about every hospice in the area does, an annual memorial service where we get together and remember the folks that we've lost over the last year, 6 months, whatever the time period may be. Uh-oh. Yes?
Do most of the other insurance companies who offer the hospice benefit follow the Medicare hospice benefit, or is there a lot of variation?
There's not a lot of variation. There's some. Generally, what they cover pretty much mirrors the hospice benefit. There are some differences in how patients get kind of recertified. So, while Medicare benefit, this might be a little into the weeds, Medicare benefit periods go in periods of 90 days, then 90 days, followed by an unlimited number of 60-day benefit periods. And at the end of each one of those, the patient has to be reevaluated and recertified as terminally ill. Okay. Now, some private insurers, their process for how that's done is different, and their guidelines are a little different, right? I called one just out of the blue just because I was curious about it. I called mine. This was several years ago. I don't have that insurance anymore. But they had a hard 6-month cutoff. So after they would cover, I want to say it was like a 90-10 split, they would cover 90%, and then after 6 months, it was all out of pocket. So I don't know that that's typical. So moving on to having the conversation. So the rest of the time that we spend will be going through a useful tool that I found. It's an 8-step guide to having the hospice conversation. And what I'll say ahead of time, and that's on these 2 bullets, there's no substitute for expertise, right, when it comes to a difficult conversation. So one of the things that I always say is and I say this to our staff, and I say this to anybody who has important conversations about important topics with people that are coming into something new. It is more important to get something right than to get an answer, right? My favorite story to tell about that is when I was in grad school, I worked the desk at our library, and we had this horrible computer system. It was old, it was difficult to use, it was this arcane thing, and on like my second day, I really messed something up for somebody because I didn't know how to work the computer. And my boss was this grouchy guy that could frankly be kind of a jerk, and he walked up to me and he goes, just ask me. Just ask me. It's so much more important that we get it right. You know, it's okay to make somebody wait a couple of minutes longer as long as we get it right and don't mess it up for somebody else. So I think it's a harsh way to say that, frankly, but I think it's important because this information, when we're talking about situations of medically fragile folks, literal life and death situations, I think it's really, really important that the information be correct. So if you're having a conversation with somebody about these topics and you don't know the answer, always find a hospice professional. Okay? And then the other thing about the 8 steps in particular, the nature of healthcare ensures that sometimes these steps will not necessarily be sequential, right? Julie, I think you'll appreciate this. It's much like the way we describe like the stages of grief, right? People don't necessarily proceed through stages of grief in a linear fashion. Sometimes it's very circular. Sometimes we go back and forth between steps. The same is true here. So, first, how not to do it. This is a headline that I saw in the news recently. I don't know if anybody saw this story. But a gentleman, I believe he was in Arizona, was in the hospital with a terminal illness. He knew generally that he was terminally ill, but late one afternoon, without an appointment, without any further notice, a cart with a screen on it was wheeled into his room, and a doctor he had never met before told him that he had about 2 weeks to live. His, I believe it was his niece or granddaughter was at his bedside, but his wife had stepped out for a while. She was not there with him. And he, was understandably very upset at this news. Some of these quotes up here are from the news article. This is what his granddaughter reported. And this gentleman died, I think, 2 or 3 days later. So this is what, his granddaughter says, I look up and there's this robot at the door. The next thing I know, he's telling him, I got these MRI results back and there's no lungs left. There's nothing to work with. I'm freaking out inside. I'm trying not to cry. I'm trying not to scream because it's just me and him. He just got the worst news of his life without his wife of 58 years. If you're coming to tell us normal news, that's fine. But if you're coming to tell us there's no lung left and we want to put you on a morphine drip until you die, it should be done by a human being and not a machine. I think that's a fair expectation, right? I think that there is a role for telemedicine in hospice and palliative care, but that's not it, right? So first, we've dispensed with a couple of ways how not to have this conversation, so now we're going to go forward with some good steps, I think. So, step 1, we're going to assess the need and establish medical facts, because this might be the most important part, just big picture, because you don't want to admit somebody to hospice if hospice is not what they need, right? If somebody is still eligible or clinically appropriate for some other form of treatment that they would like to pursue, that's what they should get to do, right? If somebody would like to pursue aggressive physical therapy or aggressive chemotherapy or aggressive, whatever. That is their right, and they should not be pushed toward hospice if that's not the correct course of treatment for them. So here's some questions to kind of ask to guide this discussion. Has the patient's condition worsened to the point that their symptoms cannot be adequately controlled? Does the patient have a terminal diagnosis? That's kind of important, right? We get, hospices will often get referrals from skilled or assisted or independent living settings where we get the referral based on the patient's need for care rather than whether or not they're terminally ill. Does that make sense? So director of nursing at facility X calls us and says, hey, so-and-so has become a 2-person assist instead of a 1-person assist for transfers. We're thinking it might be time for hospice. It might very well be the time for hospice. And that can be a guide to, and you'll see when we talk about eligibility a little bit, that can very well be something that can maybe start us thinking about it, but because somebody needs more help is not a hospice diagnosis, if that makes sense.
What about when people have things that are going on with them that are not easily terminal? Like if they have some sort of Alzheimer's disease, or even vascular dementia or something
Exactly.
like that.
Yeah. There are clearer markers that, for what typical decline looks like in dementias, and we'll go over some of that in just a minute. But in functional decline, and we'll talk about this in just a second when we talk about eligibility, but when we talk about functional decline, the way I like to describe this to folks is if you're seeing that somebody needs a lot more help, it may be time to do a little more investigating to see if there's something underlying. Do we know that there's something underlying that can be, the genesis for a conversation, if that makes sense, right? Has an attending physician or a specialist told a patient or family that this is a non-reversible condition that will only likely get worse, that it is terminal? And has the patient indicated in any way their understanding, their wishes related to their illness? So that's a really important thing to recognize as well. One of the things that you'll hear just about any hospice professional say is that the difference between hospice and other forms of care in our healthcare system is that patients' wishes and values drive hospice care versus the other way around, I think, sometimes. We really, and I say we meaning hospice professionals generally, we, I think, do a more complete job of incorporating patients' values and wishes into their care plan than other modalities of medicine, frankly, by necessity, right? So, okay. I'm going to talk a little bit about hospice eligibility criteria. You have a handout there that's got some general guidelines. So, you see these check boxes. These are kind of the functional decline markers that you'll see, some of them. So, people who have been given a terminal diagnosis of less than 6 months. Sometimes it's just that simple. Somebody goes to the hospital, they realize that the cancer that was in remission has come back aggressively. Oncologist reviews their records and their scans and says, I'm sorry, there's nothing we can do. You very likely have a terminal prognosis of this amount of time, and I'm going to call hospice. Okay. Sometimes the referral comes to us just that clean. Most times, very much not. That is definitely an outlier for that to happen. So some functional markers that you'll see in folks who are kind of just beginning this journey, right? Declining nutrition, noticeable decline in their mental status, multiple comorbidities, so multiple, very problematic and debilitating medical problems. Decline in functional status, multiple falls within about a 6-month time frame, frequent infections and illnesses. Think about somebody with like chronic kidney disease that spends a lot of time going back and forth to the hospital with urinary tract infections, right? Recent significant stroke or coma events, that's fairly straightforward. and then uncontrolled pain or other symptoms. There are some disease-specific criteria on that handout as well. Those are not hard and fast guidelines. I want to make sure I point that out. And the other thing, too, is my background is as a hospice chaplain. I am not a diagnostician. So when it comes to the clinical questions of what if there's this, and this, I can offer guideline, but it can't, be taken as diagnosis, if that makes sense. And where it says if a patient meets 4 or more, meeting 4 of these should not be understood as necessarily meeting hospice criteria, but it might be time to do a little extra digging. Okay. All right. So this next slide here, and you have this on the back of your handout, is the Functional Assessment Staging Test, or the FAST. This is used to determine hospice criteria, hospice appropriateness in patients who have dementia. So this answers your question a little bit from earlier. Generally, if you see somebody who meets about the stage 7, maybe 6, the end of 6 and beginning of 7, that's about when it's time to start thinking about it, right? Anybody stage 7 or above, that's a pretty solid time when somebody can be referred to hospice. And these are all markers of what happens. And again, it's not necessarily sequential as the brain continues to fail and it stops communicating as well with the body systems. So, once somebody with dementia is no longer able to walk, once they're no longer able to smile, once their speech is down to, just like 1 or 2 words, responses or sentences, or if it's unintelligible, that's when you're really kind of starting to talk about time for hospice. And again, caveat, not a doctor. Does anybody have any questions about this before I move on? This is a pretty widely used tool by hospice professionals. Okay. The next widely used tool by hospice professionals is the Palliative Performance Scale. Now this one's a little trickier. And I tend to try to stay away from actually assessing this myself because, again, not a clinician. FAST is a little easier for non-clinicians. But with this one, this is designed to kind of mark, in a concrete way, functional decline. So most hospice patients are coming in at a PPS of about, palliative performance PPS, of 70 or below. Now, this is very diagnosis dependent. So if you've ever met somebody that had a end-stage cancer diagnosis that was still at home and still able to walk around a little bit, still fairly functional at the beginning of that final stage, that person may be a 70 PPS, still functional, but their disease is progressing very rapidly in ways that we can't necessarily see. Now, somebody with end-stage Alzheimer's is not going to be at a 70 because they're not going to be walking. They're not going to be doing activity, right? So somebody with end-stage Alzheimer's is generally going to be, 50 or below. So these are diagnosis dependent, but I wanted to kind of show you these are the kind of conversations we're having when we're looking at somebody for whether it's time for hospice or, this person's already on hospice and this is how we're marking their decline. All right. So we'll be sitting in a meeting and one of our nurses says, he was, a couple weeks ago, I'd had him at a PPS of about 40, and now he's definitely down to 30, so he's definitely showing some decline. So this is how we kind of anticipate what's coming sometimes. Questions? All right. Step 2, set the stage. I think this is really, really important. I think in healthcare, we talked about this a minute ago with the screen, right? The actual physical environment of a difficult conversation can contribute to how it goes. The situation I led off with, the story about the nurse at the facility who didn't adequately prepare her resident for what she was going to be talking about. We were in this room. The space was tiny. There was like 8 of us in there, and nobody had brought a folding chair like this one. Everybody was in these recliners that they'd pulled from the common area. And so we're all just crammed in there. There's people behind me that I'm trying to talk to. It was just a terrible environment for a serious conversation, right? So all this stuff matters. So make the setting as comfortable and non-threatening as possible. I think this conversation, and note this here, these conversations are scary enough without the physical environment contributing to fear or confusion. So this is not always possible because sometimes we're talking about this conversation in a hospital, but the least sterile and clinical looking setting as is possible, I think, is helpful. If I'm meeting with a family at an assisted living, I generally try to find a nice quiet common area that's got, couches and a table rather than standing in the lobby, right? So it's just simple things like that that are easy to figure out. One of the things I think is really important is to distinguish between decision makers in a family and interested parties. I don't begrudge anybody wanting to have whoever they want there, right? If this particular niece is a loved support person for this patient or resident, and that patient or resident wants them there, great. Now, if somebody is coming to the conversation because they're an interested party and maybe they have the potential to derail this discussion a little bit with different we've all been in discussions, right, where there was a person in the room that wasn't necessarily helping guide the conversation. If possible, try to identify those folks prior to, right, and invite the decision makers. Again, this is something that's not always possible. Try to present as much of a safe and non-anxious presence as possible. That's body language. That is sitting down. When I used to be a chaplain that rounded door to door in a hospital, one of the things that my supervisor told me and told all of us as a department was, if you can, sit down. Because what it communicates to somebody who is in a bed when you walk in and you stand up is, I'm not going to be here very long, right? If you're going to walk in and stand up and talk over me, that just, it communicates to me that you don't have the intention of being here very long. Now, if I walk in and I pull up a chair and I'm at eye level with somebody, it tells them that I'm invested in how this conversation goes. And I think that that's important. I think of it, just in terms of a height difference, it's the same way with me talking to my 7-year-old, right? If I talk to him up here, he's doing like this, and he's uncomfortable already. Not that I'm that much taller than he is, but he's uncomfortable already, and it's not, but if I get down on one knee when he's upset, if I get down on one knee when I'm trying to teach him something or correct the behavior, and he can see my face and I can talk in a softer voice so he can hear me easier, makes everything a little bit easier, right? Step 3, assess the understanding of prognosis. I think we'd all be surprised if we knew how often folks did not have a very clear understanding of what their disease is, right? Has anybody ever seen the documentary Being Mortal? It was a Frontline documentary made a couple years ago. It talked about kind of how values guide decisions about palliative care and hospice. There's a doctor in that video, and she is asked, what is the most important question that you ask in this conversation? And she said, I want to know what a person's understanding of their disease is. Because if we don't know that, then it's very hard to make any further decisions or have any further conversation about what we're talking about. Again, this is something that's not always possible. We've already talked a little bit about folks with dementia diagnoses. So by the time we're getting involved, the person with dementia who is appropriate for hospice care isn't able to participate in this conversation, right? But then we extrapolate this to what is the primary caregiver, what is the power of attorney's understanding of this disease? What is their understanding of the prognosis? What is their understanding of the trajectory, right? So those are all important things to figure out. And I think this first bullet here, when we're talking about a patient who is able to comprehend their diagnosis, who is able to make their own medical decisions, if we are not clear with them and they are not clear about their prognosis, then they cannot have informed consent for care, right? This woman that I referenced earlier, where the conversation didn't go well, when the nurse tells her, you're not terminally ill, you just need a little extra help, I can't, at that point, obtain informed consent from that patient because she is not correctly informed, right? At that point, if she's consenting to hospice care, she's got a very clouded picture of what that means.
Hey, Brad, how do you approach
Mhm.
people's kind of thought that hospice means I'm just giving up and I'm just gonna die, or I'm
Yeah.
just gonna let my mom die?
Mm-hmm.
I think it's a big issue. It's a big concern for me.
It is, and it is a myth, right? And there is a whole section later about myths about hospice care. It is a myth that hospice means that somebody is giving up. Now, this is the chaplain in me talking. It is not my place to judge what somebody's state of mind is when they make these decisions, right? Maybe somebody has gotten to the end of a very, very long and arduous journey, and give up is the way they would like to talk about it. I'm okay with that, right? But at the same time, folks should know, and they should be presented with this at time of admission or time of consult, that hospice doesn't mean that you're going to be gone in a week. It doesn't mean that you're going to be gone in a couple of days. Hospice doesn't mean we're not going to, it doesn't mean that we're not going to give you medications to help you feel better, right? We're not just going to, I think the phrase was, if you're going to put him on a morphine drip until he dies. That's not what we're doing, right? We're providing support, we're providing care. And the emotional, spiritual realm of that, there's fair questions to follow up with that, right? If somebody says, I don't want to give up on my mom, what does giving up look like? What does, sometimes we use the word reframing, right, when we talk about somebody who wants to be healed. What does healing look like? Does healing mean that you can stay where you are in your own home, and when you have something happen, we can come treat you, versus having to take you by squad to the hospital and go through the ER all the time? Does being at home where you're comfortable, surrounded by your loved ones, does that feel more like health and in an environment of healing than, a hospital does? So we're reframing the ideas sometimes and being very specific that we're not talking about physical healing as much as, kind of the healing of the state of mind and the spirit. So does that help? All right. Where was I? Oh, this one. This can also give folks an opportunity to correct discrepancies in medical records, especially in aging populations that where patients move around a lot, whether it's from home to the hospital to the skilled facility for rehab to the assisted living to they had a bad experience at that assisted living, so they moved to this assisted living, to various places. Sometimes, and I'm sure you're going to be shocked by this, information doesn't get conveyed correctly. We went and evaluated a patient several months ago, and one of their listed diagnoses was Parkinson's disease, right? So we make a note about that in our evaluation to send to our doctor. And upon some investigation, this person was never diagnosed with Parkinson's disease. They had a central tremor that, would manifest in some trembling occasionally. And somebody had written a note in some assisted living, diagnoses list, Parkinson's. What they meant was a Parkinson's-like tremor. And it's very different. So we have this kind of running joke in our office about, when we're going out to get this information, let's verify this stuff. Like, the way Reagan talked about nuclear weapons, we trust but verify, right? And because, and the serious point about this is, if we are treating for a particular illness and that person doesn't have that particular illness, or if we are proceeding down a hospice care plan path, when there are other interventions that could actually help this person, extend their life, right? Then we've done somebody a pretty significant disservice, right? So, step 4, define goals of care. I made this point earlier, but I think it's fair to bring up again. In hospice, I think it's very true that a patient or family's values and wishes should drive their care and not vice versa, right? So we ask about people's hopes and fears. What do you, with the knowledge that you have this life-limiting illness, this terminal illness, what do you hope your final months are like? All right, we can be that clear and that open about our discussions. What is it about this journey that you're afraid of? Are you afraid that you're going to be in pain? Right? That's a perfectly legitimate thing to be afraid of. Well, the good news is that we can help keep you out of pain. Right? Sometimes goals are as simple as something like, I just want my mom to go peacefully. It's time. She's lived a long and full life. I had a family member very recently who passed away at 95 after a very long and good life, and she went peacefully in her sleep. And as these sort of things go, it's kind of ideal, right? And everybody gained some comfort, from the idea that she went peacefully, that she didn't suffer. And sometimes these discussions can be more complicated. Like, I want to reconcile my relationship with my estranged son, right? That's not something we're going to fix at time of admission. But if this person is admitted to hospice, the social worker knows that that's important to them. The chaplain knows that that's important to them, and it's something that can guide our care planning. This is it can also determine if somebody's not appropriate for hospice care, right? Another patient we sat with recently said, we realized that her chronic medical conditions were not quite as advanced as what was reported to us. And she said, I really only need some help for the arthritis in my shoulders. That's not an appropriate hospice admission, right? Hospice is not equal to pain management. Okay? So that's stuff we figure out based on just an interview with a patient and family. All right. Identify needs for care. Identify symptoms and other sources of distress that could be alleviated by hospice. Consider physical and psychosocial needs, so the needs that would be met by your chaplain and social worker. And we talked a little bit about this in the last slide. So tailor the discussion to the individual patient. Sometimes this is good to, it's good to have particular symptoms and sources of distress prior to time of consultation. But again, that's not always possible. Always good to have as much information as possible. So one of the things that we like to know prior to admission is, does this patient have extensive needs for medical equipment, right? Is this person physically compromised to the point that they can't transfer themselves? Are we going to have to order a type of lift, to get them from, their bed to the bathroom or the shower, right? It's always helpful to know that stuff ahead of time, because then I can get it ordered and there when it's ready. We like to know, obviously, allergies, things like that. Patient is Catholic and hopes that hopes that a priest can come visit her, for end-of-life sacraments. With the caveat that maybe this person isn't connected to a local parish and somebody's going to have to, do some digging, right? This is all stuff that we like to know ahead of time. Patient's family will likely need a respite stay. They're just overwhelmed with the care that this person needs at home. And a point about respite stay, under the Medicare hospice benefit, patients that are receiving hospice care in their home, so not in an assisted living, not in a skilled facility, but in their home, are entitled to 5 nights of every 30 days in a skilled facility. And it's totally covered, and it's designed to alleviate and prevent caregiver breakdown. Yes?
So different hospice providers have different contracts with facilities? Is that how that
Correct, yeah. We've done it where we have standing contracts with facilities where that's our first place we send our respites to. Sometimes it's, and especially when we start talking about farther out service areas, right? We had a patient just recently moved from an assisted living in Lancaster to a skilled facility in Circleville. So we didn't have a standing contract with this facility in Circleville, so we drew one up for this one patient. So that's kind of how that works. Step 6, introduce hospice. Hospice can be introduced as a way to achieve the patient and family's goals, how to meet their needs. Use this discussion to kind of dispel myths, some of the things that we've already talked about, and to educate on how hospice can help. Not every provider, not every person that's having this conversation needs to know everything about hospice, but some discussion points around dispelling some myths can be helpful. So, dispelling some myths about hospice. Myth, hospice is giving up. Myth, hospice is only for cancer patients. There was a long time where the primary usage of hospice was cancer, and now any number of problematic illnesses, so various dementias, end-stage anything is kind of what I like to say, end-stage kidney disease, end-stage lung disease. So all of these things are fairly common and can be used as a hospice diagnosis. Hospice means I'm going to die soon. Hospice is where you go to die. Hospice is not always a physical place. In some cases it is. There are inpatient hospice units in hospitals, in skilled facilities, freestanding units like the Kobacker House that you've heard of, I'm sure. Myth, you cannot keep your own doctor if you enter a hospice program. That is not true. Patients and families have the right to elect which physician is going to follow their care, right? Once you choose hospice, there's no going back. Also not true. A person can unenroll from hospice at any time. If they're feeling like this is not meeting their needs and they'd like, they're feeling better and they'd like to go try try aggressive treatment again, we can discharge from hospice and their regular Medicare benefit kicks right back in. Go ahead.
Can they later re-enroll in hospice?
Correct. Mm-hmm.
So do families know that they can accidentally unenroll people from hospice by calling the squad and getting, do most hospices tell families that?
We sure try. And the
So I've had families who they call the squad and they have a person transported for whatever reason,
Mhm.
and the person is in hospice, and now the hospice has to tell the family that the person isn't in hospice anymore because now they've been admitted to the hospital for
Correct.
treatment.
Right. So you cannot bill Medicare for active aggressive care at a hospital and hospice at the same time. Is basically why that happens, right? So hospice patient X falls at home in the middle of the night. His wife finds him on the floor. He's bleeding. She gets scared, understandably, and her first reaction from how many decades of muscle memory is, there's an emergency, you call 911, right? We really do try to provide, and the other hospices do this as well, try to provide upfront education about if something happens and you don't know what to do, call us first. Sometimes our advice is going to be call 911. This is something that can be treated in a hospital setting that we can't do. So-and-so has a compound fracture. We're going to send that person to the emergency room, right? And there's some tricky billing things here too, because if somebody is admitted to hospice, the hospice has to discharge to, it's called a discharge to a not contracted facility, which means we don't have a contract to provide hospice in a hospital. The patient can be billed for the full cost of that hospital stay. And so if we don't do our jobs up front, then there can be really serious consequences to this. So it's really important to do this education on the front end. I am running short on time, so I'm going to skip some of these myths, and Julie is going to email you the slides, so you'll get back to them. Oh, actually, you know what? I'm going to talk about one more. This is an important one. Hospice admission does not require a DNR order. Now, if somebody has a full code, meaning requiring chest compressions, intubation, it's not actually consistent with a hospice care plan, but my philosophy on this, and other people agree with me, smarter people than me agree with me, is that hospice professionals are the people that are best equipped to have conversations that guide toward a change in code status. So we don't use that as a barrier for admission. Step 7, respond to emotions. Recognize and respond to the emotions that you get from the patient and family when they are kind of receiving this news, that when they're experiencing this conversation. fully explore concerns raised before we, kind of offer reassurance as a way to get out of a conversation, right? That's something that people do. As the chaplain in the room, I feel like it's important to say that you don't always have to say something. Sometimes there is nothing more comforting than just sitting in silence with somebody while they cry, right? Sometimes it's even, just let somebody's tears come without even offering a tissue, right? Because sometimes I think, that says I can't handle this, right? What you're doing is making me uncomfortable, so I need you to fix it. I think it's important to just be able to sit with somebody that's having a hard time. Okay, some helpful phrases to kind of guide these kind of difficult conversations when people are responding in an emotional way. I can tell this is difficult for you to discuss, and if you want to take some time, we can. Is there anybody you'd like us to contact for you that can be here for you, as we have this discussion? I'm sorry that we've come to this point, right? So just very kind of, those are very empathetic statements, right? Where the whole idea is for me to imagine what it's like for that person to be sitting in that chair that they're sitting and hearing this news from this guy that they've never met before, a lot of times, right? So if we tread with empathy, then we can have, I think a fulfilling conversation about this. And it says read the room and see what feels appropriate. That is a skill. I don't mind saying that. Not everybody can do that. And there is also nothing wrong with being the person that can't do that, but it's important to recognize it. It's not everybody's skill set. And then the final step is recommend hospice and refer. Depending on the patient and family, arrange an enrollment visit with the provider that you might recommend. Suggest an informational visit. That's where someone in my role comes and just basically explains what a hospice program is and what we do without any pressure at all to enroll, without any sort of urgency to enroll. Give space to ask questions, make people more comfortable. Some important things to remember: hospice companies are all required to provide the same services. Just like any difference in any sort of agency, there's differences in customer service, response times, things like that. Patients and families have the right to choose their provider, so a lot of facilities have the folks that they work well with, that they're most comfortable recommending, but patients and families are allowed to choose whoever they want. Right? Patients and families have the right to transfer hospice providers only one time in a benefit period. That prevents people from, bouncing all over the place. And then patients and families have the right to revoke the hospice benefit at any time. So I think we don't need to feel like we have to have every answer for every scenario, but I think this is a pretty fair outline for what can make the beginning of a hospice conversation a little bit easier on everybody, and hopefully what can make that conversation go a little bit smoother with a little bit of knowledge and a little bit of empathy. So hopefully we all feel a little more informed and empowered and, ready to do this kind of good work. So can I answer anyone's questions? Yes, ma'am. Yes, I'm sorry. Sometimes I get in the weeds a little bit and forget that I haven't explained something. Medicare looks at hospice in terms of benefit periods, right? So the first 90 days of hospice care, that's the first benefit period. The second 90 days of hospice care, that's the second benefit period. And then kind of a unlimited number of 60-day benefit periods after that, and so at the conclusion of each benefit period, the patient needs to be essentially recertified as still terminally ill, right? And people get discharged from hospice, right? People survive, essentially. The term that most places use is graduate from hospice. That actually has its good and bad things, right? So great, we don't actually think you're terminally ill, but you've had all this help for 6 months, and now we have to pull out, so what do we do now, right? So I think it's really, really important to get this first part right. So. Mhm.
The palliative care, I mean, I understand the differentiation between hospice and that, but how does that work as far as like insurance goes, with palliative care?
Yeah.
Is that just regular care, or is that a different area?
The thing I know about this is that the clearest answer I can give is it depends, right? Most insurance providers will cover palliative care if it's deemed medically necessary. Now, that phrase is doing a lot of work, the phrase medically necessary, right? So they have to go through, these prior authorizations from physicians that say, yes, this type of palliative care, this type of comfort and pain control is medically necessary. Now, I can imagine scenarios where, insurance companies may not view something as medically necessary.
So
Does that make sense?
Make that differentiation?
Medicare does sometimes. Private insurers do as well. So, it's getting palliative care covered for the patient is more difficult than getting hospice covered, right? Just generally, I think that's a fair thing to say. Mm-hmm.
Do you think that families understand what palliative care is when they hear the term?
No, I don't. And that's one of the pieces I said in here was that it's so important that these terms be clear, right? Because I think you see hospice, palliative care, and comfort care used almost interchangeably, and they're just not. They're not the same thing. I think palliative care can be used as a stand-in for hospice because it sounds a little nicer, right? Oh, you're not ready for hospice. This is just palliative care. No, this is hospice. And it's important to be clear and to be right about that. So no, and it's a weird word. People, the first time I remember the first time I was in a palliative care, interdisciplinary team meeting with the physician, and this was when I was interning as a chaplain, and we went around the room introducing ourselves, and I was like, I don't actually even know what this is. Can somebody explain this word to me? And so I think it's so important to be clear with people and to assess what folks' understanding of their disease is, what their understanding of their prognosis is, and their medical needs. It's so important to know that stuff. All right. Well, if there's no other questions, thank you. I'll hang out for a bit if anybody has any questions that they want to ask me personally. And thank you very much for listening and for not throwing things at me.